Welcome back to Decode Healthcare with Harshul. We're diving right into part 63 of our 100-part ICD-10-CM guidelines series. Today's mission? Mastering Section IC 119F. We're talking about the strict, and I mean absolutely strict, surgical and medical complication coding laws found in categories T80 through T88. If you're a revenue cycle professional, a medical coder, or an auditor, you already know that complication coding is one of the most heavily scrutinized areas in all of healthcare. So we're going to break down the CMS official guidelines today to make sure your coding is fiercely accurate and completely audit-proof. Here's our roadmap for this explainer. We'll be hitting the cause and effect mandate, mechanical versus non-mechanical devices, surgical site infection stacking, coding post-operative pain, and finally, those tricky Chapter 19 character rules.
All right, let's jump straight into Section 1, the cause and effect mandate.
This right here is your cardinal audit survival rule. When it comes to linking a procedure to a complication, the CMS official guidelines are the ultimate authority. They completely override any textbook, training manual, or personal assumption you might have. The rule is crystal clear. Medical record documentation must explicitly specify the cause and effect relationship between the medical intervention and the condition. Just because a condition happens after a surgery doesn't automatically make it a complication, folks. There has to be an explicit provider link. So, temporal proximity, that gets a giant red warning label. Imagine you're reviewing a chart and it says, patient developed atrial fibrillation 2 days post-hip replacement. That is not a complication code. Why? Because temporal proximity does not equal causality. On the other hand, if you see an explicit linkage like AFib due to surgical fluid shift, boom, you get a green check mark. The physician explicitly tied that condition to the care provided. The absolute bottom line here is that coders literally cannot assume or infer causality based just on a timeline. If you code a post-op fever or urinary retention as a complication without that explicit physician linkage, you're on a direct path to severe audit penalties. Even for something like a hemorrhage or a hematoma requiring medical attention, you have to distinguish if it was intraoperative or post-procedural, and the provider has to explicitly state it was a complication of the procedure. We do not play guessing games with provider intent. If it's murky, you query.
Moving right along to Section 2, mechanical versus non-mechanical device complications.
For categories T82 through T85, you absolutely must differentiate between a mechanical failure and a non-mechanical issue. Think of a mechanical complication as a physical breakdown, a displacement, a leakage, or a mechanical failure of a prosthetic device or graft. Picture a dislodged joint prosthesis. That's a mechanical dislocation. But on the flip side, a non-mechanical complication is all about how the body reacts to that device, stuff like infection, inflammation, or pain. So if you're looking at tissue inflammation around a bone screw, that's non-mechanical. Nailing this difference is what ensures you're routing your codes to the right subcategory.
Let's tackle Section 3, surgical site infection stacking. When a patient develops an infection following a procedure, you can't just toss a generic code at it and call it a day. Category T81.4 demands clinical depth. You have to pinpoint the exact tier of the surgical site infection, or SSI. Are we talking superficial incisional, deep incisional, or does it go all the way to the organ or space where the surgery actually took place? The medical documentation has to specify this depth so we capture the true severity of the condition.
I want you to think of this like a mandatory math equation. We call this SSI organism stacking. Step 1 is your primary complication code, say an infection following a procedure, superficial incisional. Step 2 is an absolute mandate. You must stack this with a secondary organism code from Chapter 1. That's your B95.61 for MRSA or B96.20 for E. coli to identify the exact infectious culprit. And step 3, if that infection has progressed, you bring in severe sepsis or acute organ dysfunction codes. Remember, primary complication code plus secondary organism code. That is the SSI coding mandate.
Up next is Section 4, coding post-operative pain.
Post-operative pain has a very strict set of sequencing rules. If the pain is just routine, expected post-op pain, you assign that right to the G89 category. But if that pain is explicitly tied to a specific complication, let's say they have painful wire sutures, that Chapter 19 complication code steals the primary spot. You code the complication first, and only then do you tack on the G89 code secondarily to specify if the pain is acute or chronic.
This exact same rule applies to pain caused by medical devices, implants, or grafts left in a surgical site. If you've got a patient with a painful hip prosthesis, the Chapter 19 T code is your primary code. Then you supplement it with an additional G89 code, like G89.18 or G89.28, to identify the acute or chronic pain due to the presence of that device. The golden rule here? Always let the underlying complication lead your claim. Finally, we've made it to Section 5, Chapter 19, Character Rules.
The seventh character in Chapter 19 is a huge deal, and it all hinges on one concept: active treatment. This character is assigned based on whether the patient is undergoing active treatment for the complication itself. And here is the kicker, you guys. This applies even if the complication is related to a precipitating problem from years ago. Your focus is 100% on the current condition being treated. Let's break down those options. A is for the initial encounter, which means active treatment is being provided for the condition right now. D is for subsequent encounter, and we use that during routine healing or recovery once the active phase is done. And S is for sequela, meaning a residual effect of a past condition. So if a patient comes in for an initial encounter for an infected internal joint prosthesis, they get an A for active treatment of that infection today, even if the joint was originally implanted 5 years ago. The active treatment is for the brand new infection, not the original surgery. As we wrap up this explainer and gear up for Part 64, where we'll be jumping into Chapter 20 for external causes of morbidity, place of occurrence, and activity codes, I want to leave you with one powerful provocative thought. It's something you must ask yourself every single time you review a post-surgical chart. Is the cause and effect relationship explicitly documented by the provider? If the answer is no, you do not have a complication code, period. Thanks so much for joining me for Part 63 on Decode Healthcare with Harshal. Don't forget to hit that subscribe button, leave a like, and share this explainer with your fellow revenue cycle pros so we can all keep our coding fiercely accurate. I'll see you in Part 64.